Hey everyone, and welcome to Highly Qualified with the International Society of Cannabis Pharmacists. I am your host, Dr. Melanie Kane, and I am I have so many hats. I'm the co-founder, executive director, and president of the board of directors here at ISCPH. And I'm very excited to be sharing the space and the airwaves with our vice president, Raymond Vellky. And just to give you a quick agenda of this meeting, because of course we like to stay organized here, we are pharmacists. So we're going to start with some introductions, and then we'll talk about how our education has really geared us towards working in the dispensary. And at this point of our careers, we can talk about how working in the dispensaries and with cannabis has helped us transition out, because I know that is a lot of concern for people that are considering the cannabis space, how those skills can be transferable to other sectors of pharmacy and healthcare. So, with without further ado, Dr. Velky, please say hello, introduce yourself, tell us where
Hi
you're from.
everyone. Hi, I'm Ray. I'm from Pittsburgh originally, and that's where I currently live. I grew up here, and I went to school around here. When it went to Pitt, and became a pharmacist, and moved to Philly for a year. And my first job was as a pharmacist in a medical cannabis dispensary in Philadelphia, and I lived there for about a year, and that was about half of that time was before the pandemic, and about half of that time was after the pandemic had started. So I moved back home in around what was it, in around August. I moved back to Pittsburgh, taking another position as a pharmacist in a medical cannabis dispensary. And it was sometime between those two things happening that I think I joined ISCPH and started kind of working on some projects with you. I think I just tuned in for an episode, and or I guess I wouldn't call it an episode, but some kind of meeting, some kind of either a networking event or a meeting. And I thought it was interesting, and I wanted to use it as a way to kind of help my own. I thought it would seem like a really neat resource to just be able to learn more about the industry, and talking to some really smart people about medical cannabis when nobody really knew what was going on with that. And Melanie would be one of those smart people. But
Well,
yeah, yeah, but it was good. That was just like a cool way to start the career. And then like I said, I
let
moved
me stop you
back.
there. Let me stop you there.
Yeah.
So, because I feel like we already have a lot to unpack, and I want to pack
Hmm.
it all into one episode. So, so let's start with starting your first job out of pharmacy school. I will say cannabis was also my first pharmacist gig out of pharmacy school back in 2016. So it was quite some time ago. But I definitely did not feel prepared for the role, if I'm being perfectly honest. Yes, there was like, on the job training, but literally the week after I started, my state started to treat chronic pain and chronic intractable pain, if we're being legalese here. And that was, so different. We don't really have pharmacists dosing patients for pain, let alone any symptom. We don't really have pharmacist led dosing for things beyond, like your anticoagulation clinics, where you have very clear parameters of patient lab says this, you do that. So I think without having that objective piece definitely made it more challenging. But at the same time, it really made me feel like a clinician. So tell me more about how that transition from pharmacy student to dispensary pharmacist. Tell me about how you prepared for that, or anything like you did, or your company did, or if your school did anything. I don't remember when you said you graduated, but I I'm assuming it had already been legalized in Pennsylvania when you graduated at that point.
Yeah, so I graduated in 2019, and so I think the law was passed in 2016, I want to say, but it began like to actually be realized in 2018. I think is when you start seeing dispensaries, and everything's kind of set up. So it would have been like towards the end of, yeah, me finishing school. I think I had one friend, one of my classmates did a rotation at a medical dispensary in another state. But yeah, I think it was just kind of beginning to blow up a bit around that time. And so I yeah, my the first job, I mean, I had been looking into kind of a ton of different jobs. So as far as preparing for it, I mean, it all kind of happened fast. Some people I knew had been really anticipating this and had been really preparing and working towards being a medical cannabis pharmacist. Like I definitely was not. I was trying to get a residency, didn't match, and was kind of like, I don't want to work in retail, so I'm going to try to figure out what else I can do. And that was what I thought was kind of an interesting alternative. That I was like, huh, it seems like it's. I heard kind of mixed things of what like pharmacists would do in a medical cannabis dispensary, and some of it was based off of somebody um, I had at least reached out to and asked questions as a pharmacist in Ohio. But in Ohio, they don't require they were, at least at that point, they didn't require a pharmacist in a medical cannabis dispensary, whereas PA you did. So it was more of like it was an entirely different role, more specific to consulting and being sort of on standby. And every I think dispensary needs to have somebody like that, but something to that effect. Whereas in PA, you needed to have a pharmacist on site, and so it was, of course, like became all of a sudden a demand for an actual that was an area of space where people were taking jobs. So yeah, I started at the like I said, this it was herbology in Philadelphia, and I guess there, I mean, yeah, we didn't we'll backtracking a little bit as far as getting any like specific training for to work in a dispensary in Pennsylvania. You need to do a 2 hour online training, and then there's some kind of 4 hour training that medical professionals need to take, and that would be anybody who's uh, giving someone a certification, so a physician or a nurse practitioner or PA, or somebody who's going to be a pharmacist would also fall under that same medical professional uh, title, I guess. So you need to do a 4 hour training for that too. So you get a little bit of that. In school, I didn't really get any. Maybe there's one class, one lecture that I had on medical cannabis, and it was more pertaining specifically to dronabinol in the context of CINV. But I think there was also maybe one lecture about it was just about illicit drugs, and one of them included THC. So that would have been the most like pharmacology I'd learned about it. But yeah, so it was completely uncharted territory, and I'd say, like I said, I didn't really train a ton for it, other than those sort of, as you could picture, these modules. You're just kind of clicking through, and you're trying to learn what you can, but not, realistically, you're not going to learn a ton from that. And then so a lot of it was just on the job, and what it turned out to being was basically when you're working in a medical cannabis dispensary in at least Pennsylvania in 2020 or 2019, is you're checking people's certifications, making sure that the doctor who put the certification in didn't put any restrictions, such as like any restrictions against like them using like a vaping form of administration, or some kind of maybe cap on THC to CBD ratio I've seen before. So those are very rare events, but that's like a technical reason you're there. And then also to just counsel patients who have questions, which of course there are a ton of patients who have questions, because you have some people just are curious and would ask questions about their medications in general. But I think specifically you're in this weird space where the physician is certifying the patient, not prescribing anything to them, and then sending them to a dispensary to buy stuff for themselves without really much direction. Usually, maybe some doctors are telling them some things, but they wouldn't know what specific products are going to be at the dispensary without like looking at the menu for that dispensary. So they're really counting on the pharmacist, or in Pennsylvania, they're usually called something like a patient care consultant or a patient counselor or something like that, but it would be what we'd picture as a bud tender in another state, just to be able to know how to recommend things to somebody. And so from the pharmacist standpoint, that would be really a lot of people didn't want to talk to a pharmacist because they already kind of either knew what they knew, or would look up the information themselves, or might even be kind of skeptical of somebody who's called a pharmacist. And then, but you'd also have, but yeah, you would have some patients that would be maybe they're older, or maybe they're not necessarily older. Maybe they just haven't really ever heard of any, that have never been exposed to cannabis, or maybe a couple times in their life had, and now their doctor's telling them for their chronic pain to take this thing or try this thing, and they don't know how to dose it or do anything with it. So that becomes very much on me, the pharmacist, to talk to them, to tell them about methods of use of different products that could make sense. Like maybe you could try a topical, or maybe you could try a tincture where you're taking a few drops under your tongue, and this is the dose, and and it's, by the way, like, good luck somebody figuring out how many milligrams of THC they're getting from a tincture when it's just only giving you a concentration of like THC on the back. Nobody knows how to do that math without, maybe now with ChatGPT we can, but
The answer for everything. Well, I think that brings us to a great point. Like a lot of it is so separated, so delineated from like regular medicine and pharmacy that we don't have these crystal clear monographs of drug information and drug labeling that we would have to fall back on. And now obviously, like, the products that you were dispensing in, I already forgot the dispensaries names, I'm sorry, but in Philly versus Pittsburgh, like, they're different products. It's not a guarantee that, product A is the same in both stores. So it's like so challenging to have that consistency when it comes to a plant-based medicine. And that's why patient education is so important. And that, I think, is like one of the best skills that I would say is transferable from, having that patient educational experience in the dispensary. Like, you're having to explain something for a lot of people, like from the very start. Like, they don't know what THC CBD is. You're just throwing like acronyms at them, which I'm sure people already are sick of acronyms in the medical world, but but especially if you're a patient with like these chronic debilitating symptoms, whatever it may be, whatever is like their qualifying condition for their entry, it can be very overwhelming. So I think, pharmacists have that very unique touch point where they are that in between. We can speak, I don't want to say correctly, but we can use, scientific jargon when we're talking to other doctors and nurses and other healthcare professionals. And then we can kind of simplify it and, tell patients, when you're feeling this, when you're feeling that, do this, do that. And I think that is something that for me, it helped me transition from the dispensary to like a MTM type role, where I was doing more like telephonic type educational outreaches and stuff, which is more similar to my current role. And then I also feel like, with Pennsylvania in particular, like having to go through those certifications and looking through and, seeing if there's any exclusions. I don't know. It just feels like more order entry to me, which I feel like you're in the hospital setting. So that kind of transfers there as well. Are there any other skills you want to highlight that you feel like you really took on while working in the dispensary environment and um, took them with you to another pharmacy-based role?
yeah. So I think just as you highlighted, there isn't really any clear monographs for these products, so you have to do a lot of your quote unquote own research when you're kind of looking into this. There's of course papers. You'll find they did some study where they looked at 20 people, and 10 of them had this response, or 10 of them in this group and 10 in this other group. They're usually pretty small studies, or maybe that you can look at a large study for a drug like Marinol or something and try to extrapolate that, because that's synthetic THC. It should in theory be pretty similar to like a THC product that we'd have. It doesn't have a whole lot else going on with it, which, by the way, a lot of products were like that, which didn't have all the other terpenes and cannabinoids and stuff. So you could like kind of try to kind of game out through what is out there, but it's still just, in the end of the day, there's no FDA labeling. So I think it just taught me to kind of be resourceful and have to look look in weird places to find information, to help the patients the best I could, kind of thing. So yeah, I think that would be something that would be helpful later, because I, working in, if you're in retail, you'll get questions that won't show up in like wherever thing you're planning on it being, micromedics or whatever. So I think it helps to just, yeah, that it helps there, but definitely then also in a later role working in like children's hospital settings and and a lot of that's also off label or kind of murky area kind of stuff. So I think just it made me more comfortable with my own decision making with limited information, I think is what medical cannabis did.
That's great. Well, I love it. Well, is there anything else you want to talk about? I know you're our first episode, so tell us more how you're highly qualified. No. That might be the tagline. Actually, I'll take this opportunity to talk about some of the education that we've done together because you kind of alluded to it already. But we
Mm.
have gone through some changes in the society where we had really we tried to have like distinct committees, like this one's focused on education and this one is clinical practice and research and that one is quality assurance, and then it ended up being that the types of projects that we were putting forth were just so overlapping that we would kind of have these conversations in different committees and like have the same repetitive conversation, and it just felt like it wasn't effective for actually getting stuff done. So you were one of my co-authors for our institutional policy considerations, which was our first research paper. That was very exciting. Was able to check that box off to be a published author of a peer reviewed article. We're working on some things now. I think you and I both have an affinity for um, cannabis in the elderly. I think, I mean, just with our experience directly, seeing the potential uses for it and such. What else are we doing?
We have a glossary.
We
I
have
don't
our
know.
glossary. Yes, I think that's also important because, well, I don't mean to judge your program, but you guys have like the weirdest names for things. Like, I'm familiar with the normal terms. Like, okay, I get keef and I get dabs and I get
Oh
hash.
yeah,
But then
sand
you bring in
and
like crumble cookie. I don't even know what you guys are calling it. Like, it's just
yeah, I don't know.
flimsy duck. Like, you guys just like make stuff up. But that's like the cannabis industry in general. Like, you have to like,
Mhm.
because you can't patent genetics. So you have to like patent the other dumb things that are part of it. And so that also is like a reason why. But
Shatter. We have shatter is one of the
yeah,
concentrates.
what are
That's a
you
cool name.
shattering? Like, what is that even a verb? Like,
It kind of looks like glass, I guess, and it kind of shatters, I guess, if you
I
hit it
like the ones
over
that make sense.
something.
Um, but anyway, so yeah, glossary. I love that we're doing that, especially because we're doing it more from like a patient friendly version. Because my goal, my vision is to have like these resources available because I would love pharmacists to have prescriptive authority. I would love it. But I think there's just too many opposing forces that whoever the regulators are that just, I guess it's like a conflict of interest because if you're selling the product, and I get it, but doctors do that too. So looking at you too, AMA. Anyway, so I'd love to have prescriptive authority and have pharmacists be like more of a provider, more of, not just that resource of knowledge that's in the community that, people just kind of get mad at when their insurance doesn't pay for something and it's the pharmacist's fault. Like, makes no sense to me. A lot of things I would change with the healthcare of this country, but things that I can change are getting pharmacists to be more involved, more educated, and more aware. I think one of the biggest issues with anything that has a stigma, whether it's opioid use, a history of addiction, whether it's cannabis use, medical or recreational, I think, we as pharmacists, as any healthcare provider and professional, you can't just look the other way. It's like, oh, I'm just going to pretend like you're not on cannabis and hope it doesn't interact with your medications. Like, what a silly thought, because that's not reality. And so, we know it interacts with medications and anesthesia, like, and we need patients to be honest and have trust and faith in their providers. Otherwise, what's the point? So, my hope is that we can provide those resources to pharmacists to be more like independent in their decision making and their clinical decision making, maybe working with providers. I'd settle for mid level, like PAs and NPs. I'd be fine with that. Put us in there. Put me in, coach. I guess we just have to convince Medicare because I feel like Medicare, CMS sets that up and then we can all follow suit. But yeah, let's not even get into that rabbit hole. But yeah, having like a glossary of terms, having like we've done our formulation guide. We have to like finish getting the graphics for all of them, but it's like that's our specialty. Like I would remember working in a pharmacy a long time ago, and doctors would be like, "How does this come? Is this a pill, a capsule, a tablet? Like, what am I ordering?" And it's like, I got you. I mean, that's definitely lessened with e-scribing because it's like drop downs, but it's like someone's got to contain all this knowledge, and I sincerely doubt like the big pharmacy organizations are open to this. So I don't mind being the pioneer. What else have we done? Um, CE, we've done a lot of continuing education. I feel like that's very important. I wish we had like enough content to be able to have like if you could have like is it like a certification? Not a certification. Yeah, a certification. Because that has to get like renewed. But like there's just not enough. Like we can't be the only ones pumping out like 20, 30 hours of CE every year for a renewal. Like that's just too much. As much as I'd love to do it, it's just like it very easily can get repetitive. So hopefully people that have watched our CEs, we have some free ones too. Hopefully they've learned something even from that. But I don't know, just kind of seeing how the industry is going too. Like I feel like my state, I don't know about your state. I'm in Minnesota, but in Minnesota we went adult use as of like a year or two ago. And part of the law changes is that like you don't need a pharmacist in there anymore. It can just be someone that's had like 16 hours of training in cannabis, whatever that means. I don't think they've even improved anything, but it really feels like they're pushing the pharmacist out, which I get. We're expensive, but like we provide a specific service. And so if people don't want to pay for that, or if the dispensaries and whatever don't want to pay for that, like I would love insurance coverage. I've dabbled.
So
I have dabbled.
is that specifically is that medical cannabis or yeah, medical dispensaries that they've totally gotten rid of the pharmacists in Minnesota?
I would say basically, I
Huh.
don't feel like if it's effective yet because they had like a period of like rule making, whatever. So like you could like come back to them and whatever. But I'm pretty sure like that section was not really altered in any way. So I can't remember what they're calling them. Something similar to like cannabis clinician though. And it's supposed to be like fairly certain. Like you don't even need a pharmacist there. You just need someone that's done this little 16 or so 20-hour training. Look it up. Jamie,
I
pull it
feel like
up.
I'm Jamie right now. Let's see.
Every podcast needs a Jamie. But it kind of like shook me being like, wow, we were like the second state in this country to require a pharmacist, and adult use comes and just pharmacists go by the wayside. So kind of sad to see. I feel like I've definitely experienced cases where, you know, as great as we call them like technicians kind of. So they were more like it's probably similar to what you call, I think we call them
Patient care
patient
consultants.
counselors. Yeah. So it's like a very generic term. Like, what does that even mean? But not a pharmacy technician. Like, they don't have like that type of training, but in that similar like assisting role. And they would do like a lot of device training and like help with product selection. But like ultimately, pharmacists had final say. But there were definitely times where I was shocked at what they were saying. And I was like, just wait for me.
Yeah,
Which,
exactly. And I think
yeah.
that was definitely my experience with it is like the patient care consultants or patient counselors. Again, I think one of the places I worked was one and the other was the other. They were super good at their jobs mainly, right? They were able to explain to people basically the things that would be yeah, as a pharmacist would have to in another setting explain how to use some kind of device. They'd be good at explaining that kind of stuff and making and recommending some things, right? But I think once you get into the territory where we really care about how like there clearly are people who respond pretty negatively to even small doses of THC, unfortunately. And I don't think that anybody, I was never really impressed with anybody outside of a pharmacist that were able to dose that way, because that's just kind of not what we think of. That gets into more of a medical territory, and like having that intuition about that. But I think, and yeah, so then you get somebody getting RSO, and for people who don't know what that is, it's like a really highly concentrated, basically like a syrup. It's like 80% THC and
Add it
like a
to the
small,
glossary.
yeah, yeah, we should. And you take like they say a half grain size of rice, which like good luck, like that's actually how you're gonna try to dose it out. And it would be, that would be a dose. And if you actually looked up what the dose would be, it'd probably be like 5 to 10 milligrams of THC at that amount, which would be like a gummy or something. But I don't know. It still kind of hits people differently, and that like that's not one to one. I think was interesting. Like I know from uh, friends tell me experience, the 5 milligrams of THC in an RSO, or 10 milligrams of THC in an RSO, might not feel like 5 milligrams, 10 milligrams of THC from a gummy or some other thing. It's not. They're pretty. I think everybody kind of has different, even subtle differences in absorption or whatever it is, or maybe it's difference in some of the terpenes, some other pharmacology that we that's a whole other topic we should have. But I don't know. I mean, sometimes it just seems like it's just the smallest differences, and maybe that's like it's in the placebo effect stuff. I don't know, but that is really tricky territory to just navigate with, uh, even for a pharmacist. So I think, yeah, I think you definitely want to have somebody that has experience recommending doses, or recommending, or at least is sensitive to when you're told by a patient about an allergy, a side effect, a reaction, to not dismiss it as like, oh yeah, it happens to everybody gets a little too high sometimes or something. It's kind of sometimes the general ethos that you kind of have in a dispensary setting. And maybe we should be like, wait, no, time out. Like that sounded like a horrible reaction that you had, and we should probably like avoid that, like, or at least work our way up to that in a really, slow way.
I saw
Um,
something that was like the functionality of cannabis medicine, and it true like any good medicine, like even gabapentin or like any opioid, like you don't want it to completely floor the patient. So it's like same
yeah.
so too with cannabis, like we still want their executive functioning, like, and this is, I think, isn't it like officially considered a psychedelic? Like this is going to affect your perception and processing and all that.
Mhm.
Like that's going to affect your like prefrontal cortex and everything, and I guess other parts of your brain to sound smart. But um, like, I feel like when people are using it for a medical purpose, like they want to retain that executive functioning. And if they're using it like recreationally, or, not for a medical purpose, and they're just looking to feel altered, like they don't care about that. So definitely seen when like people in the dispensaries will like leverage their own personal experience and be like, oh, well, this is what I like. And it's like, oh my God, you don't have MS, you don't have this type of cancer, like you don't know what this person is feeling. But I would never, like, I'm all about empathy, but like I would never put myself in their shoes and be like, this is what I would do. It's like, here's what I can tell you about these drugs and these products and potential interactions. Please experiment safely. And just breaks my heart when people do have side effects. I've definitely experienced like counseling patients on that, and it's heartbreaking. Like it's very sad when it happens. Like I'm glad it's not life threatening. It's I say
Yeah.
it's not life threatening. It's life altering because it does kind of make you take a step back. And at that point, if you were coming to the dispensary to see me, you had already tried everything else and you had failed everything else. Otherwise,
Mhm.
you wouldn't be trying this Schedule One drug that a lot of doctors don't even want to touch, don't even want to look at, literally can't even carry it in the pharmacy because of its illicit status. So yeah,
Well,
a lot of
I,
stigma,
I I have
demonization.
I was gonna say I have a specific story about that. Well, it's fresh in my mind. Is this? It's not really that. I don't know why it's fresh in my mind, but it kind of stays fresh in my mind. This person, this patient, was they wanted something to help with their sleep, and I gave them. I recommended this tincture that in a dose that was like I think it would have turned out to being like 4 or 5 milligrams to start. I would later start by recommending lower doses for people if they were naive to cannabis for this reason is that they took like four, like I said, what would have been like 5 milligrams, and it sounds like they just had a really one they couldn't fall asleep, but it sounded like they were just kind of stuck in a really alert slash maybe paranoid state slash whatever. And it's not that that's like, well, again, like nobody's dying there. It's not life threatening. And but yeah, like you said, it sucks because in part, I mean, they're probably not gonna use that again. And as somebody not for sleep, or they'll need to totally be. I mean, the reaction to it depends on the person. And like I've had some people be willing to retry it, and like I remember my interaction with this person was like they're not going to. So like then that person's just gonna go back using to thinking that Ambien is the only thing that can help their sleep or trazodone or whatever, but they could probably do use some cannabis product and get relief. They just in some dose, but that just really freaked them out, and it was like a traumatic experience for them. They just
Yeah,
not want
it's hard
to
to
not want to
restart
do
when
it.
you have that. Like
Yeah, yeah.
the fear, the PTSD of experiencing that again is very scary. And I've definitely encountered people, um, not very often, thankfully, but they have like sustained effects to intoxication. So it's like they'll get that anxiety, paranoia, whatever that altered state is, whatever you want to, dysphoria, whatever you want to call it, and it will persist. Like the longest I had seen in a patient was like 26 hours, which is like, that's terrible. But like, with obviously all this recreational cannabis that's out and about in all these different states and territories, it's like I've seen people have that sustained effect for weeks to months. And it's
Mhm.
like, maybe it's interacting with something that was, innately in them. Like they were already kind of teetering towards like a manic episode or something like that. And this just kind of put them over the edge. But it can be very scary. And like I said, life altering. So, I mean, I'm a big fan of start low, go slow, stay low forever. Well, I don't know why I feel like there's also a school of thought that's like, let me just get to this target dose of whatever milligrams, or like we would have like when I was in the dispensary back in my day, in my prehistoric days, we would have like 2.5 milligrams as the lowest THC, and then it went all the way up to like 25 per capsule. And I remember people are like, "That's where I want to be," and I'm like, "No, you don't. That is not where I will start you ever, no matter how much you beg and plead." Like, I'm not looking to document a side effect with the state. That's what I would say. I'm like, I'm not looking to do more work. Like, you have an adverse reaction, I have to report it. No, thank you. So, so I feel like that kind of made them like revisit it. And I
Yeah.
would say like maybe like 5 to 10% of patients actually went to that highest dose, but we never started there unless they like came from an experienced background, like they were in states and doing that amount. And even then I feel like anytime you transition, it's like it's a challenge, just like with any medication when you're transitioning, like, you gotta start lower than you would. And I don't know, it just reminds me of like when you switch insulins. You don't know how the person's going to react. So give yourself some space.
Yeah, also it's just and like insulin, it's more expensive if you have to use more. So
Yeah,
you should try to use less.
exactly.
the
Love it.
goal should be to use.
Well,
But
Ray,
thank you so much.
thank you. I will be posting this to our beautiful podcast, and I'll be sharing it on, I don't know, what do people usually say? I'll be sharing it on your, wherever you listen to your podcast. But I hope to see you again soon. Maybe I will have you back after we publish our next research paper. That would be fantastic. Good little motivation. And then, yeah, thanks, Ray. Bye, everyone.
Thank you, Melanie. Bye, everyone.